welcome everyone who is here so far to the KCQVIC forum, and I guess lay out a couple of the ground rules, which is just if you have any questions at all throughout the forum for any of our speakers, please do utilize the chat function. We really love to have a good ongoing dialogue going on in the chat. We also love to save some of those questions for the Q&A portion, where we will then have all of the panelists kind of there and ready to answer any questions. So as something comes up, definitely drop it in the chat and we'll either talk about it during the forum as well as potentially that can come up at the end during the Q&A. So with that, I will go ahead and get started. So yeah, thanks again to everyone for joining today for our KCQVIC forum. So today we are presenting on a regional strategy to address opioid crises, and we're giving an update on our high IQ project. So a little bit of background for you. So for those of you who are not aware, just a little bit of information about high IQ, the Healthcare Institute for Innovations in Quality. We have a vision of Kansas City delivering the highest value, most equitable healthcare in the nation. And our mission is to catalyze and facilitate multi-stakeholder collaborations to improve the quality and value of healthcare in Kansas City. And kind of with the origins of the QVIC and high IQ, we know that health systems are struggling to improve the value of care. We know that we're currently operating in a volume-driven healthcare and fee-for-service healthcare where, there's high cost and, questionable quality at times. And so we're really trying to get to value-driven healthcare where we can improve quality of care at a lower cost. And no one really knows how to do this, right? So, we developed this regional strategy with high IQ and the QVIC of really bringing multiple stakeholders together, the providers, researchers, purchasers, payers, community patients, so that we can innovatively think about how we can all come together, our little school of fish here, and kind of come and tackle, the changing healthcare landscape, which we know is going to take a lot of innovative thinking. And really what we're doing and developing here is kind of moving from, a learning healthcare system approach to really a learning healthcare network, where instead of, just one unit or one hospital implementing an innovation in care, we're really trying to get multiple hospitals to work together and collaborate on quality and shared priorities so that we can all learn together and make a big impact on health outcomes in our region. And a little bit of background to kind of lead into our speakers today. So, how we started developing, how we landed on this opioid project as one of our main projects was, in 2018, we started meeting with a number of stakeholders in Kansas City, particularly a lot of the healthcare hospital leadership, as well as payers and community-based organizations. This is just a snapshot of not even remotely close the number of stakeholders we spoke to. So I apologize if your logo's not on there and you're one of our partners, you're just as important. But we started meeting with all the stakeholders to really identify what are the biggest priority healthcare topics in our region. And we met with hospital leaders, with hospital associations, with CBOs, patients, payers, state and local health departments, and researchers, and really try to understand what are the biggest things in our region that we need to tackle. And from those interviews, we had a number of topics. We had 32 different healthcare topics that were a priority in our region. And from there, we kind of moved into a survey where we identified what topics are actually actionable and high priority, things that we could accomplish in our region. From there, we move that down to 11 topics. And then from there, we started these, like today, these monthly forums where we talked about some of these different healthcare topics and presented, where we're presenting with hearing from different stakeholders in our region. And at the forums, we did a number of qualitative methods where we then parsed that down further to 6 different topics that were of high priority in our region. And there, with input from our strategic advisory board, we really landed on 2 projects for regional implementation. Those are opioid management, which you'll hear about today, and then transitions of care for heart failure, really with an emphasis on population health and the social determinants of population health approach and social determinants of health. So those are kind of how we landed on our projects 1 and 2, our 2 regional projects that we've started with. And so, those are kind of how we landed on our two projects, but really High IQ has kind of three main strategies by which we achieve our mission and vision. And the first of these, as I just mentioned, is those regional QI projects. And so that's where we as a community are working across a number of hospitals in our region. This is a map here on our two different projects on opioid management and on transitions of care for heart failure. And then, in order to actually do this regional QI work, this is not easy work. This is hard, and it really requires knowledge and training and implementation science. And so we also developed, which is our second kind of arm, is training and education and implementation. Like, what is the basic science of how you change care? How do you implement evidence into routine care in communities? And so we developed TIARA, which is training and implementation actionable research approaches. And that's also now been moved into coursework at the university. And we'll also be offering certificate programs through High IQ as well as CE in that in 2023. So if you're interested, let us know. And then our third arm is, why we're all here today, which is dissemination and engagement. We have our monthly community forums where we talk about these different healthcare priorities in our region. And what's really great about these forums is, it's just a way for the community to come together. And we have these really short presentations from a number of different stakeholder voices on one topic. So today you're going to hear from all of our amazing speakers on opioid management and Casey Epic in particular. But at other forums, you'll also hear from, a payer, a provider, a community-based organization, a patient, and so you really hear, short presentations and perspectives from a number of stakeholders, which really provides for a rich discussion and kind of brainstorming on next steps. And then, excuse me, so in terms of our two regional projects, as I had mentioned, we have opioid management, which is our project is Casey Epic. This is engaging patients in care coordination. And this is a partnership that we've started with the Missouri Hospital Association. And you'll hear from all of the stakeholders that are active in this project in today's session. And then our second project is the transitions of care for heart failure. And here we have this is our, heart failure carousel from patients who present to the emergency department with heart failure into being admitted to the hospital, their transitions home, and then living at home with chronic heart failure. We have a number of different interventions, 4 different interventions that we're working with hospitals in our region to implement and evaluate the impact of. And so why we're all here today, again, is the forum. So as you can see, today is our update on the regional strategy to address opioid crises. And then just so you have the rest of the year, you can see that our next sessions are on health literacy, caregiving trends, burdens and breakthroughs, and you'll hear an update on our transitions of care project in November. And also, I just wanted to let everyone know on this call to kind of stay tuned. This fall, we'll be deploying our survey to set the agenda for next year's forum. So please do give your voice to that. And with that, I will turn this over to our first presenter, or presenters, I should say, which are both Dr. Holly Hagel and Dr. Ife Liu, who are going to be presenting an overview of the Casey Epic project from a pre-implementation perspective. So the floor is yours.
Thank you, Stacy. I'm getting my screen ready to share, so somebody let me know if you're seeing the full slideshow.
Looks great, Holly.
Okay, good. Thank you. So as Stacy said, we have been part of the High IQ QVIC since its beginning. We're just reflecting back. I've been coming to the forum since 2018 for sure. And then we've been in an attack opioid team, one of the 2 regional teams, since 2019. And when we were planning this session, and you probably didn't see this in the agenda, but I'll let you know, we did have a strategy on how we wanted to present this, because as High IQ is growing and thinking about taking on more regional teams, maybe in the future, they wanted to have a structure around how we were presenting information. So today we are taking a pre-implementation perspective, but we did pick up this project and it was already in existence. So there's some things that don't exactly match pre-implementation. Then our next speakers are going to talk about the implementation themselves, findings, and then we're going to take the community perspectives, in which we'll hear from the local ComCare, and then from the Missouri Hospital Association. So there was some strategy when we were planning the agenda in that sequence I just wanted to share with you. But Dr. Liu and I are going to talk about some pre-implementation definitions, but also the specific models that we're using in our enhanced implementation evaluation of the Casey Epic project. So we are going to share with you today an update on the process maps that we've been working on with all the hospitals that I don't know if you were able to see them all, but Stacy did outline them, the regional hospitals that we have been working with. We're going to share the implementation model, the EPIS model that we've been using, and then some updates on the logic model that we are. And I don't want to get too deep in the weeds in any of these, but we did want to share with you that the implementation science structure that we're using. So from a pre-implementation perspective, I just wanted to share this definition with you that very little, basically, there's been very little focus on this very important time. This element of the early phases of implementing a project, that preparing the setting, which is maybe a hospital. In our case, it's hospitals, but it could be, treatment facility. It could be an outpatient setting. It could be a community coalition. Any setting for the introduction of a new intervention, a new way of doing work or an additional way of doing work. And understanding what factors contribute to the optimal engagement of all of the contexts that will be involved. So we just pulled out this definition to set that stage that ideally you want to start before you launch intervention, understanding the pre-implementation environment. Now, because of the work that QBIC did with all of those stakeholders that Stacy reviewed, we did pick up this project when it was already active. And so it's not a one-on-one fit when we apply some of the implementation models and the logic model to some of the processes that we've been doing, because this work is live. It's going on every day in the hospitals, as you will see. We wanted to share with you some of the long-term goals of the whole project, obviously, and then in specific to the implementation and evaluation component. So the primary goal, and we all put this forward in our thinking, is that we want to help people with opioid use disorders and understand how they get better, right? And so we're actually identifying the pathways for those who have opioid use disorders with recovery support services and how it is actually being implemented in real time in Kansas City's engaging patients in care coordination. And we're doing this by using a robust mixed methods evaluation, which you will hear from Dr. Olds and Dr. Lafayette that are, an update on our qualitative and our quantitative methods. And we are also implementing, an implementation science framework to understand some of the barriers and facilitators of this project within the hospital system, but also within the region. I like that slide that Stacy used about learning systems into learning networks. And I do truly think that we are and have been working as a learning network here in Kansas City. Okay, I'm going to turn it over to Dr. Liu to talk about process maps.
Thank you, Dr. Tego. So in the next several slides, I'm going to talk about process mapping. Next slide, please. And the participating hospitals in Kansas City EPIC include University Health, formerly Truman Medical Centers. It has 2 sites, Hospital Hill and Lakewood, North Kansas City Hospital, and Excelsior Springs Hospital. So when eligible patients visit the emergency department of a participating hospital, they are referred to peer recovery coaches by the physicians. To develop the process maps, we met with various people representing these hospitals. They included the physicians, either in the emergency department or behavioral health recovery, social workers, qualified mental health professional, and hospital administrators who are responsible for emergency services, recovery services, and transitions of care. They provided insights from the standpoint of hospitals toward the implementation of EPIC, in addition to what is described in the manual of the EPIC program. According to their inputs and the manual of the EPIC program, we developed a detailed process map for each hospital. Then a finalized detailed process map was verified by each hospital. Based on the 3 detailed maps, we came up with a high-level map, which summarizes the process for all 3 hospitals. Next slide. We recently completed the detailed map for Excelsior Springs Hospital. I will use it as an example to briefly walk you through the process of the EPIC program. On this graph, a blue capsule represents a start point or an end point. A blue diamond represents a decision point. A blue rectangle represents a task or a step. A green circle represents a checkpoint, and an orange folder represents a document. I know the map is too small to view the details, so in the next 2 slides, I will split it into 2 parts, pre-coach versus post-coach, to make it easier to view. Next slide. This slide shows the pre-coach process. Excelsior Springs Hospital has 2 patient referral sources. One source is patient admission from its emergency department, and then patient referral to ComCare. The other source is patient referral from its community partner or outpatient specialty clinic. The red color here indicates differences from the high-level map. For example, if you look at the upper right, the physician initiates conversation about EPIC. The patient gives verbal agreement to be referred. The physician calls the recovery coach, or the patient calls the coach with the physician's presence, and the coach assists the patient. And this part is not in the high-level map. Next slide, please. This slide shows the post-coach process. To enroll a patient into EPIC, the recovery coach verifies patient information with the hospital, and the patient fills out the consent and the initial contact form. The coach follows up with the patient at 1 month, 3 months, 6 months, and 12 months. And you see a dotted big rectangle here. The rectangle and green arrows mean that the discharge below or the activities above could happen anywhere in the rectangle. In addition, the 7 activities above the rectangle, peer supports, mutual aid support groups, supported housing, sober living environments, formal treatment, pharmacotherapy, and overdose education, they are considered as engagement activities with recovery coaches. Next slide, please. The high-level map summarizes the 3 detailed maps of participating hospitals. It has the same post-coach process as what we just went through. But for the pre-coach process, the difference is that it has a simplified process applicable for all 3 participating hospitals. Now I will hand it over to Dr. Hagel.
Thank you. So we want to dive deeper into the implementation models that we've been applying throughout the project. And I do know that we have a representative from the Opioid Response Network on here today. So I want to say thank you to Sherry and the team there, because some of this early work around the EPIS model did happen with their help through a TA technical assistance request. So we are applying the implementation framework of called the EPIS model: exploration, preparation, implementation, and sustainment. This model it has been published and developed by Dr. Gregory Ahrens, and it's used very widely in implementation science, and it has 4 phases that are very well defined. And these phases align with the implementation process. I'm going to just take you through a couple of slides that show you how the KC Epic aligns with those phases. And then the model also talks in terms of the context. And again, context would come up in a pre-implementation, but it certainly comes up when you're looking at things from an implementation perspective, meaning where the intervention is happening, the outer system and the inner organizational context. So we'll go through that. And then really the bridges of it bridges the actual evidence-based practice or intervention that's being implemented so that you can understand based on those factors and context, how what facilitates the uptake of that practice or might be a barrier to the uptake of that practice. So this is the model. As you can see, it's a cyclical model where things feed into each other, the phases: exploration, preparation, implementation, sustainment. I know it's kind of small for you to read all of the inputs for the outer and inner context, but a couple of them are leadership, on both contexts, outer and inner. And then the bridging factors are, we fit here, the QBIC opioid team, we're purveyors, trying to bridge the context and some of the to help sustain the implementation or understand the components of the implementation. So that's the model we've been applying. I'm not going to read this slide to you. I just want to highlight the 4 phases here on the far left. And then these are the definitions. I'm not going to read them, but just for example, in the exploration phase, obviously the state funded and it had based on some federal and state funding, started the project. All of the leadership teams, were involved, and the various stakeholders like the Missouri Hospital Association, which you'll hear from soon, and ComCare, which we're all obviously very relevant in the exploration phase. In the preparation phase, the process maps that Ife just went through are vital to our understanding of what are the commonalities in processes across the hospitals that are implementing the very same intervention. In the implementation phase, it's the actual live phase that they're doing the intervention. And then the sustainment phase is, from the outer context perspective, focuses on how is this been fully integrated into the day-to-day operations. For our perspective, that would be from the hospital's perspective. The hospitals are totally integrated the KC Epic project, and they're able to sustain it regardless of any external funding that might go away. They're going to sustain this process going forward. So when we look at the outer context, and again, I'm not going to go through all of these, but it just highlights who the stakeholders are from each of the outer context categories that I was saying was so hard to see in the model, the whole EPIS model. So, from the leadership perspective, stakeholders that you would expect. The client perspective in this case is represented by ComCare, not directly the clients themselves, although they service the clients in one-on-one. And then from an inner context, again, the same, some of the same categories, and we just crosswalk them for the particulars of the QBIC opioid initiative. So what are the characteristics of each of the participating hospitals? And hopefully when you see some of our data, as you could even see in the process map, there are obviously variabilities because of different hospitals having different processes, being located in different regions and having different actual community needs. One of the things that we've already learned is that even though hospitals might be in the same system, they actually operationalize KC Epic quite differently. So that is something that we have learned. Okay, and then lastly, I'm just going to review this. I don't want to get in the weeds, and I want to defer my timer right at the 15-minute mark, in which we are applying logic model. We are in the midst of trying to apply the implementation research logic model, which is a published and valid, well-established implementation logic model, to our project. So we're trying to walk through the determinants, some of the actual implementation strategies that have been used, those mechanisms that facilitate those strategies, and then what are the particular outcomes. So we're at a little bit of development time, we'll say, on this piece of the project. And really the key thing is that this is a live project. We have to look at the context. We also have to look at some of the data in order for us to truly understand what are these determinants and strategies that are being used in order to understand some of the outcomes, so that we could really fine tune what will facilitate this So it could be broadly, implemented across multiple hospitals. What are the key ingredients or factors that help implement this intervention, which the intervention is the peer recovery support specialist through CommCare and Casey Epic. So I'm going to stop there and hand the baton off to Dr. Feedback and Ms. Brown from CommCare. I'm going to stop sharing and mute.
Good afternoon. Again, my name is Kristen Feedback, and with me I have Jennifer Brown. Okay. So I'd just like to welcome everybody. What we're going to be going over again is just giving you a brief overview of Epic, and then Jennifer has some success stories and a little bit about her history. And so we've titled our part Hope Dealers. Okay.
I'm sorry, I'm gonna jump in. I don't know, we're seeing the presenter view. I don't know if you want to, right there at the top where it says display settings, you can, in the middle top, up higher and then to the left. Do you see where it says display settings? Oh. If you wanted to try and reshare, yeah, you can just, we just have to click the like swap, yeah, presenter view or whatever. So then, yeah, do you see at the very top of that screen?
Yes.
It says display settings.
Jennifer, come over here. I don't see it.
Or we can.
Just a minute ago.
Or maybe if you go to the very top where there's a green bar and it says view options, maybe you can swap displays.
Yeah, I was trying to say display settings right there on the top there.
But you got to take your mouse higher. Your mouse is too
higher.
low.
Yep.
Keep going higher. Keep going higher.
A little bit higher.
It won't go any
Almost high
higher.
as I can go here.
Do you
Oh,
have a green bar that says you are viewing?
Well, it says display settings. So if they, if they click.
if you have a
display-
second screen, then look at the other screen and it'll be on the other screen.
Like, otherwise this will be fine.
Okay.
I can pull them up too. I have a copy of them. I can share.
And I can pull it up as well.
Okay, why don't you just pull it up? I think that's the best thing you can do.
Sure.
Okay. And I am pulling up, Kristen, give me the title of yours.
Epic Hope Dealers.
And I have it. If you just stop share, I could just share and keep clicking.
Okay, thank you.
Okay,
Okay, here we go. I got it.
Thanks,
Do
all.
this, where the shows. Okay,
there you go.
where the- oops, sorry.
Thank you.
Sure, of course. Okay, seeing it?
Yep.
Okay, just say next.
Okay, next. Again, sorry for that. Okay, so I'm going to give you a history. So in late 2018, CommCare agreed to implement and lead the EPIC program. And as Mr. Billings is going to share with us about how the Missouri Hospital Association kind of divided the different regions, and also the Missouri Department of Mental Health was involved as well. Our funding comes from the Missouri Department of Mental Health, and the program was launched in April 20th of 2019. The counties that we serve are Jackson, Clay, Ray, Platte counties, and also it's available to any Missouri resident who is 16 or older. So while we started focusing on the initial launch of opioid overdoses, EPIC also expanded to substances in general, alcohol and other stimulants in 2021. Okay, next. So the key components of the program is, one, we connect individuals to treatment. We have EPIC coaches, which Jennifer will go through and discuss what their functions are and how they add value to the team. But we're trying to bridge the gap from active use to active recovery. We also try to connect individuals to recovery-oriented services. There are resources within our community that we have, particularly in the Western region, focusing on housing, food, clothing, and more. And so we utilize those resources in our community to link with the client. We also support clients with barriers that keep them from successful recovery, such as some of our coaches do attend court hearings if that's applicable. Also, sometimes getting to that first initial mental health appointment, our coaches will accompany a client to those as well. We really try to focus on building relationships with our partners that can provide services to clients as well. So we have a lot of connections with our mental health centers and other agencies around the surrounding area. We do conduct follow-up contacts, and that is again to try to reduce the gaps between services and just making sure that our clients connect with the services that they need. And if we need to connect them to even further resources, we do that as well. Next slide, please. So, you know, a lot of people, when they talk about what is EPIC and how is it structured, so it starts with a clinical coordinator. Here in the Western region, we just had our clinical coordinator move out of state, so that position is open. But Jennifer Brown here next to me has stepped up, and she is our interim director right now. She's also the lead recovery coach, so she directly supervises the 5 recovery coaches. I'm going to let her go into a little more detail about the qualifications of our coaches, because I think that's important as well. Next slide, please. Oh, okay. EPIC program partners. So these are the mental health services or the mental health centers that we typically coordinate and partner with. Okay, it was comprehensive mental health services, but now it's rural. University Health, Behavioral Health, SWOPE Health Services, Tri-County Mental Health Services, Rediscover, and then Heartland Center for Behavioral Change. And then, of course, our state partners are Missouri Department of Mental Health and then Missouri Hospital Association. And with that, Jennifer, I'm going to turn it over to you. And if you want to, under the values part, talk a little bit about the qualifications for the coaches. Thank you.
Hi, everyone. I'm Jennifer Brown, and I just wanted to share a little bit of my story just to give you an indication of our team, because my story is not 100% unique. So I started using drugs several years ago, which it progressed over time from pain pills clear up until I was an IV user. I was basically using anything that I could shoot up. And I had an opioid overdose. I was pronounced dead when paramedics arrived. Fortunately, Narcan was there and they were able to revive me and bring me back. About 6 months after that, unfortunately, my partner at the time, he had an overdose and he succumbed to that. And there was never anyone that intervened during all of the hospital visits or 911 calls where someone helped us and said that there's help available. You can die, you know, this is serious, you don't have to live like this. That never happened. That conversation never took place. And I thought about that a lot over the years after his death. So when I found out about the EPIC program, I said I was going to work there. And so here I am. And like I said, my story is not unique. Our team consists of 2 people who actually went through the EPIC program. We have another coach who has been on MAT and has successfully been off for several years now. And then we have another certified peer coach who is extensively trained in HIV and AIDS. So we're able to meet a lot of people in the community where they're at based on our own personal stories. So as far as the value that we bring is, from my personal experience, if someone came in and they were trying to tell me about this disease that I was struggling with, and I knew that they had only read about it, and there's a lot of things that happen in that life that you can't write in a book. So I would shut down and not listen. So the value of calling EPIC when we have these individuals in the hospital is when we walk in that room, and start telling them, I'm just like you. I've been in that bed. I've shot up those drugs. I've been to jail. I've lost my loved one. I had warrants for my arrest. You can clearly physically see these individuals relax and they open up, and then they're more prone to listen to what we have to say. And with that, there comes success and recovery, and those successes look different for everyone. We have a lady who got referred to us. Her significant other overdosed and died that morning. When the police arrived, they had found him dead, and she had a warrant for her arrest and went to jail at the worst possible time that she could. And the hospital referred her to us. We typically, if they're in police custody, I mean, we can't give them services because they're not available for those. But the coach went above and beyond and went and visited with this person at the hospital and heard her story. She walked with her through that journey of going to court and speaking on her behalf with the judge. She was able to take a free phone call from the jail. She successfully got her out of jail to go directly into treatment. This person completed her 30-day treatment a few days ago. She's in sober living now and should be getting her ankle monitor off in the very near future. And that's just one of many success stories that we have. We had another guy that was going back for a probation violation because he could not stop getting high. A coach went to court with him and managed to get him into treatment, and the judge was lenient and hopeful because Epic was there. And that's a common thing that we hear. Oh, you have an Epic coach? Okay, we can look at something different now without just handing out consequences. So we're able to keep people in the community drug-free and stable. And it's just as rewarding for us as it is for them. So can we, next slide, please. Okay, so I just wanted to go over a few numbers that we have over the last quarter. For the last quarter, at the which would have been April 1st through June 31st, we have at our 3-month mark, we had a 67% engagement rate, which is phenomenal for people that we have enrolled in our program. Throughout that quarter, we had a total of 205 referrals that have come in over a 3-month period. Depending on the weather, our referrals can fluctuate, but we have seen a consistent uptick in the referrals, which can be good or it can be bad. It's sad that we have more people using drugs, but excited that they're getting help. So, okay. And then just to elaborate a little bit more on our success stories, one major success that I have with an individual I was working with was the harm reduction aspect of it. It wasn't like an overnight, he went to treatment and got better. It was, I gave him so many boxes of Narcan. He probably took most of our supply, but he's alive now and he got to almost a year of recovery. He did have a reoccurrence, but Jen was there with Narcan again and he's still alive and he's trying again. So we meet people where they're at, regardless of what that looks like. We're going to meet them and help them overcome whatever barriers they have to successful recovery. Okay, so I think we need to turn it over to.
Sure. Yeah, I can jump in if you'd like. So thank you so much for your presentation and for your story. That was wonderful. So next, yeah, we turn to now we'll be hearing from kind of the mixed methods evaluation of KC Epic. And so we'll be hearing from Dr. Danielle Olds, who's Manager of Outcomes Research at St. Luke's, and with High IQ, the Healthcare Institute for Innovations and Quality, as well as Dr. Tracy LaPierre, who's an Associate Professor in the Department of Sociology at the University of Kansas. So.
All right, thank you. Thank you so much. And I just want to say it's been incredibly inspiring to work with Dr. Feedback and Jen and all the peer recovery coaches and the staff and Sean and everyone who's been involved in the KC Epic program. It's been a really fantastic experience. So now Dr. LaPierre and I are going to talk about the mixed methods evaluation of KC Epic. There you go. Okay. So a mixed methods approach that we're taking for this, we chose because it's more thorough for implementation and evaluation analysis. Specifically, we're using a convergent design. So basically what that means is we take our qualitative results, which would be findings from the interviews that we're doing, and we take our quantitative results, which would be findings from the data that we receive from the healthcare from Heidi. And we bring those together and we compare them and see how they inform each other, see where similarities and differences may be. And so then those are convergent results that help us have richer findings. So for the quantitative part, for a quantitative evaluation update, we're working with the Hospital Industry Data Institute, which is Heidi, of the Missouri Hospital Association. They are linking ComCare data with hospital records using unique identifiers. One of the advantages of this is that we'll be able to compare outcomes of those with opioid use disorder who enroll and engage with Casey Epic with those who don't. So we'll really be able to see the impact of the Casey Epic program. Some of the outcomes that we're looking at are inpatient and ED utilization. At the moment, Heidi's been able to match about 80% of the records, and we'll be meeting with them over the next couple of weeks to work on strategies to be able to match even more so that we have a really rich and complete data set. And this will provide researchers, so our team, with a de-identified data set of ComCare and hospital data. And the de-identified means that we don't have any way of identifying individuals who may be in the data set. And this will help us answer our quantitative research questions. So next I'll give the qualitative evaluation update, and I'm going to specifically focus on facilitators and barriers in implementing and sustaining a regional opioid peer recovery coach program. And this was a poster that Dr. LaPierre and I presented at the Academy Health annual research meeting this past June. And Academy Health is the largest health services research conference in the country. So it was a really great opportunity to be able to present the Casey Epic program and receive a lot of interest from those in behavioral health. In fact, they had, after I presented, they had a peer recovery coach there from a program in Texas who came to talk to me a little bit more about the program. So for this part, I'll talk about the interviews that we did with administrators, staff, peer recovery coaches involved in Casey Epic at ComCare. We've also done a lot of interviews with ED staff members, but for this presentation, I'll focus specifically on ComCare in Casey Epic. So methods, so again, this is a qualitative study and it's part of a larger mixed method study to evaluate enhanced implementation of a regional peer recovery coach program. These are interviews that we've done with 6 program staff and peer recovery coaches April through December 2021. And those interviews are ongoing. The interviews were recorded and transcribed. Our data analysis, we used Deduce qualitative software to facilitate that. Our analysis included immersion, team coding, and interpretation. New codes were generated throughout the process and discussed with the team. And for this portion, we took an inductive approach. And then data codes were aggregated into themes and analyzed for linkages across themes. Now I'll get to the really good part, the results. And I'm going to specifically focus on 4 themes that were related to facilitators and barriers of program administration. So the first theme was data entry, access, and analytic expertise. So when the Casey Epic program first started at ComCare, they didn't have an electronic health record system. And so data were entered onto forms and then transferred to a spreadsheet. And then after electronic health record migration, reports were much easier to generate. They are able to generate reports using a lot of descriptive metrics But program administrators noted that they wanted the capability to be able to better explore relationships in their data, to be able to show program success. And so we're hoping that our partnership with them, that we're able to do some of that to inform their program decisions. So a quote that illustrates this, particularly in the beginning before they had an electronic health record system, a staff member said, "This intake spreadsheet was incredibly disorganized. The information was just none of it was entered the same. It wasn't uniform. And a lot of stuff was missing as well. So we didn't actually fully have the numbers available to us." And this really illustrates the importance of these types of programs having some sort of electronic health record system. The next theme is around relationships, and there's really strong relationships between ComCare administrators and the Missouri Hospital Association and the Missouri Department of Mental Health. And this really helps to facilitate access to hospitals as well as resources. And then the relationships between the peer recovery coaches, the treatment facilities, and also other community supports and resources are really crucial for program success. So I really like this quote. Then the Missouri Hospital Association, help make connections with area hospitals that partner with them. So they might have a particular hospital that says, "Oh, we have this problem over here." And then they might connect us with that hospital to provide support. They also provide state level advocacy, like with a legislator, to make sure that the program continues for general funding. The third theme was program staff turnover. So turnover of program administrators and peer recovery coaches is often due to low pay, poor fit with the role and expectations, and burnout. And this is not in any way unique to ComCare. This is a problem throughout behavioral health services, substance abuse services, and really across healthcare in general. There was a story on NPR earlier this week about issues in California with a lack of psychiatrists and how that's really impacting the state. So this is not something that's unique to ComCare, but definitely a barrier. And this is one of my favorite quotes. "Because in all reality, we start our peer recovery coaches at $15 an hour, and you can go to McDonald's and flip burgers for more than that. So you have to have a real passion for this job. You have to have a fire burning in your soul to help people in this situation." And then the fourth theme was around funding. So the program has stable funding. However, a program administrator was concerned about long-term sustainability given the ebb and flow of behavioral health funding. Program sources for the program are often earmarked for specific substances such as opioids or stimulants. This has changed a little bit, and I don't know if Sean was going to talk about that a little bit. The program administrators wanted flexibility in how program funds could be spent. And they also wanted to be able to expand the program for more community referrals, but funding limits capacity. And a quote that illustrates this theme is, "My suspicion is that if we end up getting extra money, it will be, there's an earmark for opioid program, there's an earmark for stimulant program, and those would be very specific. Like we would funnel people to those coaches specifically. But it'd be nice if we were all just one big happy family and we could just do whatever." So I think that really illustrates the need in this space to have funds that are flexible enough for agencies to be able to meet the needs of their communities. And I will turn it over to Dr. LaPierre to talk about conclusions and implications.
Thanks. So today's review of key findings focused on 4 themes related to facilitators and barriers that were identified through interviews with EPIC program administrators. And these items provide insights for best practices related to implementation and sustainability that can inform the development of peer recovery coach programs to support those with substance use disorders. Specifically, peer recovery coach programs need a robust electronic health record system that can easily generate useful reports. There's a need for support and competitive pay for administrators and the peer recovery coaches. Close relationships between program staff and State Hospital Association and other partners, as well as local resources, are very central to the success and the smooth operation of these programs. And there's a need for stable funding that allows for program flexibility. Next slide. Okay, future directions, next steps. We're of course going to continue doing interviews. There's been a lot of turnover among some of the program administrators. So we're looking forward to interviewing some new administrators and additional peer recovery coaches. We haven't begun interviewing clients yet. That's also coming up in our future directions. We're just starting to gain access to the HIDE data. And once we could more thoroughly analyze that, we'll be able to integrate it with our qualitative findings as Danielle had described. And of course, we're also looking for additional evaluation funding mechanisms to help us carry out these additional next steps. Next slide. One of those funding mechanisms is a CDC grant proposal that we have under review. It's currently being considered for funding and they're meeting next week. So everybody send your good grant vibes our way and hopefully we'll be able to secure this funding. Our colleague, David Jarmolowicz, spearheaded the CDC proposal and was instrumental in bringing all the pieces together. David was a key member of the QVIC opioid evaluation team since the beginning. And I just wanted to take this moment to acknowledge his valuable contribution to this project. Unfortunately, David passed away unexpectedly a few months ago, and he will be greatly missed by all of us on both a professional and personal level. So the grant proposal that we all worked hard on this past spring together, we titled it Rigorous Evaluation of Strategies to Prevent Overdose Through Linking People with Illicit Substance Use Disorders to Recovery Support Services. And we appreciate the strong collaboration between, ComCare, Missouri Hospital Association, the different members of the research team in putting this together. If we could get this funding, it's about a $2 million grant that would provide 3 years of funding for more thorough evaluation of KC EPIC. We identified 3 primary aims: to conduct a systematic process evaluation of the implementation, to determine its effectiveness in linking and relinking eligible individuals to recovery support services, medications for opioid use disorder, and other recovery-focused services, and to assess and evaluate the outcomes of KC EPIC participation on recovery. Just in the interest of time, I'll just say a couple other things that's a little bit new instead of going into more details on all the sub-aims, but we're gonna look at both systematically evaluate the process, so assess implementation fidelity, those process maps that Ife had shared with us earlier, how well are hospitals and different members of the recovery team following those processes? Are there things going on with implementation that could be impacting outcomes? We're going to be looking to identify barriers and facilitators to implementation within and across sites and determine, excuse me, the acceptability and feasibility of the intervention to all the different stakeholders. That aim 2 is going to focus on some of the short-term outcomes at different phases of the intervention, and also look at the individual, community, hospital, and program factors that are associated with them. And then the third and the final aim there, here we're looking more deeply at the impact of EPIC participation on patients' recovery journey through an outcomes evaluation. And these include changes in healthcare utilization, including uptake of the medication, ED visits, and inpatient hospital admission. We're also looking at 2 other outcomes that we've not looked at yet, including changes in recovery capital and the value of the EPIC program. So recovery capital includes physical health, support satisfaction, accommodation satisfaction, psychological health, and quality of life. And we're also excited to have Kate Villain, a health economics research professor, join our team, and she will be conducting a value assessment of KC EPIC, including the return on investment for payers and long-term cost utility. So that's what's next, and hopefully we can pull together the funds to do it. So now I'll turn the time over to Sean.
It's super exciting. Good afternoon, everyone. Let me see if I can figure this out. How does that look? That look good?
Perfect.
All right. So good afternoon, everybody. Again, I'm Sean Billings. I serve at the Missouri Hospital Association, and I love serving in this space. I like helping out people who need help getting recovery and treatment. So some of the objectives real quick. I'm going to spend just a little bit of time going over some data that some of my colleagues, Matt Reedhead and Josh Grotzinger from Heidi, put together. Very telling, especially in the last couple of years through COVID. And then just some quick updates on the Opioid Settlement Fund, the launch of 988, and then provide some updates on statewide EPIC. So just real quick, and I know that I'm preaching to the choir here. A lot of you guys have seen maybe not this slide and this data, but wow, this really speaks to a story that we've all heard many times. And as you can see from this slide, we have seen a significant increase pre-post. I don't know why the percentage isn't on here, but anyway, it's a 36.3 increase pre-post from COVID. So we almost saw a 40% increase pre-post. Oh, I'm sorry. There it is right there. Yeah. Now we have it up till September 2021. So, I mean, it's really no surprise as all of us were socially isolating. More of us, especially those who might have been afflicted with use disorder, we were less likely to go to the ED, where in the past we probably were. We're a little bit more fearful of getting COVID, bringing that back to our family members. So at the end of the day, though, what this means is we have more work ahead of us. In this slide right here, man, as you can see at the bottom, yeah, hospitals still are serving very thoughtfully in this space. But when I think of the Seans and the Shaunas in the state of Missouri who are passing away from this, it's in their own home, right? So as we look at programs like Connecting the Dots driven throughout of Missouri Institute of Mental Health, I believe they're sunsetting their 4th year, starting their 5th. That whole model is to lift up first responders, EMS, law enforcement, to provide some professional development, some self-care resources, and also to get them to help serve also along our side, help with naloxone distribution, and help connect community members who need help that are refusing transport to the hospital, connect them to a program like EPIC, right? EPIC is definitely not the only program out there that they could leverage. There's wonderful resources in your neck of the woods and statewide. And then other location, wow, almost, 3,600%. So these are the Seans passing away in quick trip stalls, at come and goes, at, Motel 8s. So again, anything that is community driven, street outreach, more resources definitely need to be afforded to that space, just so we can reach those community members. So we're seeing this when I look at statewide EPIC data and other programs. The bulk of who we serve they're in that 20 to 25 to 34 age cohort. But my take home out of this slide, this is grandma and grandpa, the increase of our grandmas and grandpas, aunts, uncles, children. This is everybody. Everybody is experiencing an increase. And then with males and females, here's the breakdown there. Both are increasing. It seems like the higher spike, at least percentage-wise, was with female. No surprise here, right? You might as well that's synonymous, synthetic with fentanyl, and it is pretty much in everything. We had a young man, Central Region EPIC. He thought he was eating a THC gummy, but unbeknownst to him, he almost passed away because he was given a THC gummy that was laced with fentanyl. And that young college student almost passed away. And there's also another nasty drug, not just unique within your neck of the woods, but it's hitting statewide and pockets of the nation, and that's xylazine. And xylazine, which is an animal tranquilizer, itself isn't creating the overdose. But just like everything else, the xylazine is being cut with fentanyl. It's creating the respiratory depression, the subsequent overdose. All of that to say, we're finding fentanyl in everything. And it is a huge problem throughout the state and nation. What do we have here? So this is just, I mean, we can see here, you know, through COVID, we saw a dip in ED utilization. There's no question. These next couple of slides are going to drive that point home a little bit more saliently. Here in the top left for fiscal year 2019, you can see that, and then when you weave with those numbers and percentages, they're dipping, right? It's like getting lighter and lighter. Now, granted, when you look at some communities, there's still high prevalence. And then certainly when you look at that percent change from 2019 to 2021, there's still pockets that have seen increases, and they're highlighted in red. But for the majority, we've seen decreases throughout the entire state. And again, that's because we were staying in our homes. All of us were. Same thing with our pregnant friends. The women carrying child or children, they weren't going seeking care either. There's my mouse. And then this right here for all of our fancy PhDs who actually understand what all this is. This is where Josh and Matt Reedhead got all of this wonderful data, and they synthesized it and put in that nice slide deck for all of us. So some challenges facing Missouri. And I don't know that I've really tinkered with this slide too much in the last year or so. You know, fentanyl is everywhere. This is a huge problem. Methamphetamine is making a big comeback. And I suspect in part it's because the availability is everywhere. You know, it's easier to smuggle just because per pound, it's not like marijuana. And there's a lot of interest in it, right? So the market economy is driving that. We need more psychiatrists. We need more coaches. We need more behavioral health clinicians across the board, people serving in this space, you know, as well as tangential or ancillary services like EMS, like law enforcement, that also they're being forced, especially like law enforcement, you know, if I have mental health malady, is it appropriate for me to call 911 or a loved one? You know, probably not. That law enforcement officer probably isn't the most suitable person to come and respond and take care of me. But, you know, truth be told, they're in that situation every single day. So we need to do our due diligence, lifting up those workforces too, to help with harm reduction efforts, to align them to programs like emergency room enhancement, which is very similar to EPIC in that they basically handle the mental health components, whereas EPIC handles the substance use disorder. But it's so critical that we provide those professional development opportunities for everybody who has an opportunity to serve in this space. Again, it takes a village. Social determinants of health is part and parcel to our work. So concurrent to getting Sean, me, to walk through, let's say, Tri-County to engage in treatment, our coaches are having to navigate transportation barriers, food insecurity, maybe justice involvement. You know, that's a lot of weight to put on my heart as the consumer. I need someone to help me navigate that too. Our coaches do the best that they can. We do have flex funds to help, but I'll tell you what, we don't have enough. We don't have enough money. So again, the coaches do the best that they can, and they work their tails off. Stigma, stigma, stigma. Yeah, you know, I think in time, I've seen a lot of hearts change, but there's still a lot of hearts that need to be changed. And, you know, use disorder is not a moral failing. It is a chronic brain disease, and we need to just beat that war drum over and over, because that sentiment, you know, those people, or why can't they get their stuff together? I mean, we have to appreciate just how tough and how profound this use disorder impacts the brain, the functioning. And then COVID, enough said about COVID. So opioid settlement, we've got a lot of funds coming into the state, and we've got a lot of work to do. It's 458 million and some change. It's going to be diffused over 18 years, and there's specific buckets and state spearheads who are going to get that. I do know recently, within the last couple of months, they expanded who is going to receive some of that. I know the Office of State Courts Administrator was pulled in the fold, and that is to supplant additional funding for our treatment courts. Missouri does fantastic work through the judiciary, through treatment court modeling, and then also Department of Corrections got a small slice of that. Hopefully, how is that going to equate for us? Down at the third bullet, we're going to have more Buke waivered physicians, more access to pharmacotherapy. We're going to have more naloxone on the streets, more leave behind kits with our partners, more therapy, transportation, so on and so forth. A lot of good is going to come out of that money. One project that I'm excited about that I will share just real quick. So the Department of Health and Senior Services reached out to MHA a couple months ago, and they're going to get just a small chunk of change of that appropriation. And one of the projects that they want us to help support is beefing up surveillance infrastructure within emergency departments, specifically around fentanyl exposure. So what that position and funding is going to do is we're going to pick on 7 to 10 hospitals that are willing to serve. And we're basically going to provide the cryo vials, the transportation infrastructure, and pay $75 per sample obtained. None of those labs have to be done in-house. Those are going to be sent up to DHSS, and then DHSS in turn is going to feed it up to CDC. And again, the whole reason behind this is anecdotally, we know that fentanyl is everywhere, but we have to have more definitive information and data around that, just so we can go after additional funding to address it. And then 988. Dr. Feedback can speak to this more eloquently than I can, but based on what I know, Missouri's launch has been very successful. ComCare does have that contract in the Western region in your neck of the woods. It went effective July 16. One thing that I will call out on here is, and I just recently learned this, that the text in the chat functionality wasn't enabled yet. And I guess that's going to be turned on here in a couple of weeks. So another thing that caught my attention, and this was shared with me by, I think, Natalie Cook from the Missouri Behavioral Health Council, was the first week you guys saw, like, you were just inundated with calls. And the question I had of her was like, well, did you guys have the staff to absorb it? And she said, yeah, then. So I don't know how things are going and if that volume is still at the same pace, but man, that's a lot of calls. But what a valuable resource for Missouri and for the nation. And really going to help out law enforcement and other first responders and family members that, are in acute crisis. So engaging patients in care coordination. How am I doing on time? I'm doing really good. So a couple of things that haven't been shared. So back in 2015, and before we launched at Behavioral Health Network in the Eastern region, we spent a lot of time as far as, well, what model are we going to use and what's the chassis we're going to sit this program on. So we reached out to Anchor ED in Rhode Island. That is basically who we stole. Now, granted, we reached out to them and had a lot of great meetings with them and got their blessing, but we basically, derived a lot of our nuts and bolts from them. So Espert, and I know you guys are very familiar with this, and if you're not, it's a simple program. It's an evidence-based model. It's lifted up by the Substance Abuse and Mental Health Services Administration. And simply put, we're screening folks, right? We want to provide an efficacious brief intervention. As applied to EPIC, that in part is going to be the overdose education, the naloxone distribution, maybe fentanyl test strips. Medication-assisted treatment is a core underpinning of our efforts. It's not medically appropriate for everybody, but for those Sean's that it is, our Jens and our other coaches are going to work their tails off to get me in as soon as they can. And then obviously that connection to treatment, critical. So a couple of things here that they have not mentioned. One thing I do want to call out, unlike the Western region, Springfield, Branson, and Southwest, and Columbia and Central, the Eastern region has not yet expanded to include stimulants and alcohol. And the reason is, man, they've got a lot of community members they serve already. And out of those 15,000 community members that we've served to date, around 12,500 have been served in the eastern region. So they just don't have the budget to absorb alcohol use disorder and stimulant use disorder, at least not today. One thing that I will share, we have 32 coaches serving statewide through EPIC. We started with two coaches and 2 hospitals. Here's our footprint to date. This little magnet on the left-hand side, I probably should have found one that was more centric to the Western region, sorry, but this is for our Columbia friends. And we slap those magnets on all the metal surfaces that the ED folks will let us slap them on. So just some of our swag. And then some really cool things popping up. So we've been working for, gosh, it's probably been over, well, a little less than a year with Lake Regional Hospital and one of our FQHCs, Federally Qualified Health Centers, Central Ozarks Medical Center, to stand up an abbreviated EPIC program. And the reason why I say abbreviated is we're not going to be able to have the 24/7, 365 capture because we don't have the infrastructure, but we can do something. So what we're working out is basically a digital referral for next day response. And then for those referrals during normal business hours, and that's Monday through Friday, like traditional banking hours, we will be able to respond that same day. But more to come on that. And then we are in initial pre-planning down with another FQHC, Missouri Highlands, and then Poplar Bluff Regional. And what is this last bullet? So just going back to that one slide, looking at where the community members are passing away, it really speaks to the need for us to align what we're doing with more of the DOTS programming, and more specifically, align our work with the first responders that are boots to the ground in the community that are saving our lives every single day. But once they stabilize, the community members don't really want additional help. So for us to really stretch a little bit to create that connection with the coaches, it's been a missing piece. And I know EMS especially, and all of our healthcare friends, they've been hit hard these last couple of years, but we still have work to do. So we gently nudge as appropriate and meet them where they're at as well. So this right here, I should have reverse engineered it, but I'm going to go back real quick. And then I'm going to go back up. So that data that I'm getting ready to speak to is fed off of these 3 papers. And it just, again, speaks to the efficacy of medication-assisted treatment, our efforts, and very interested to get these types of data, numbers, whatever it is, the good, bad, and the ugly, from this research, because this is what we need to take to our legislature when we go and ask for more money, because we need more money. There is no question. So, why are people leaving? And certainly this is not exhaustive, but if I'm a pregnant female, you bet your bottom dollar that I'm afraid to go in and seek any care, because I don't want to get hotlined, and I don't want the child that I have in my womb to be taken once I give birth. And I certainly don't want my 2 young ones at home taken. So I'm fearful. Right? Or I've got an active warrant. And for some reason, I think if I go seek care, they're going to call and like run me through mules and NCIC and find out that I've got an active warrant. There's all kinds of stuff. And then obviously cravings, intense withdrawal. It's much easier if I can just go take care of that, calling up a buddy that I know is a hop, skip, and a jump away, just so I can feel normal and function, than it is to go through the whole thing of like maybe accidentally breaking my arm to go and get a script, or some of the stuff that we do to basically feed our use disorder. Inadequate treatment of withdrawal. So basically what they're showing is 12% of patients providing only a follow-up appointment and/or outpatient treatment, and 72% engage if they're on pharmacotherapy. Now, I mean, that's a pretty robust statistic. I'm not a professor, but that seems statistically significant to me. They're onto something. And again, I have the QR codes there. Lots of good stuff. And I really like this. When I read and saw this, now I've read similar literature, but the B team, the buprenorphine team, I love that, right? Every hospital needs that. assuming they've got view waiver practitioners, but a lot of good stuff in there. I know that was a lot. Oh, I just went over by 1 minute. That's good. So let me stop share. That's all I got.
So that was fabulous. I mean, I really want to thank all the presenters. What a terrific overview of this program. It's been going on for a long time. A lot of work's gone on into creating the program, into beginning to evaluate it. And you all have just done an absolutely superb job. I wanted to encourage everybody who's participating by Zoom to please submit questions to the chat, and I'll try and monitor that as well. But I had a lot of questions, and not any priority, but just in the order in which they were presented. I'm really curious, Holly. There's a lot of focus on the rigor of implementation science and how important it is before you do these programs to really plan out exactly what you want to accomplish, how you're going to measure and evaluate it, all the models and the rigor. Here, you had, I mean, the train had left the station, you had to jump on. Do you think that, there are, how valuable do you see a lot of the pre-implementation work as we think about the next high IQ initiative? How important is that pre-implementation work, defining a lot of those measurement strategies? And do you think that there would have been recommendations you would have done differently had you done that work up front, like, data collection, et cetera? How do you see the value of the science part of implementation science?
I think it was almost a year ago, when we presented last summer, and we talked a little bit about the implementation, research to science, research to science gap. It's about 17 to 20 years from when evidence-based practices gets vetted in, randomized clinical trials. The evidence builds up, it gets deemed evidence, and then it goes into practice. It takes us about that long to get it to full-scale implementation. I feel like if we spent more time at pre-implementation, when we're seeing things come out of the literature, that maybe we can shorten that. That's the ultimate goal, is to shorten that research to practice gap. And having that pre-implementation work, one of the things, I don't think I said it when I was presenting, but just overall, and we have a lot of people on this call, I noticed today, that do a lot of implementation work that I happen to know personally, so please chime in, is having the right champions. That opened the doors. Like, you guys had the right champions gathered through the QBIC work that you did, all of that work with the C-suite leadership that opened doors to understand why cardiac and opioids were important to them. And then they connected us to champions that, these hospitals only represent a small amount of hospitals that are actually implementing it, that have actually gone through our interviews and our process maps, right? There's more hospitals that are engaged in it than actually we've mapped out. But those are sort of like the early adopters in my mind, who are willing to look at those implementation characteristics. And but going back to your question about what I would do is really work on the champions. I mean, I think we spent a long time getting the into the door, even after you guys were already in the door. Then we spent time trying to explain to them what we wanted to do.
From Sean's comments, it sounds like there's going to be an opportunity to continue to expand and grow, this much needed intervention. Do you feel like you're gathering the right information to accelerate the adoption and the more complete implementation of this in future hospitals, or even to suggest improvements to the hospitals that are already doing it?
I do, and here's why. When I look at the quadrants of how we're doing data collection, like the process maps, the qualitative data, the preliminary results coming out of that, and then even the quantitative data, you can see crossover in some of the results in the areas that we need to focus on. So to me, that means it's optimistic that when we are more to scale and understanding the results of KC Epic, it'll be more broadly applicable to other hospitals. And I think when Danielle said, oh, a recovery coach from Texas stopped by and saw similar characteristics in their poster from their implementation, tells us that we are seeing that saturation, and that's what you look for in data, that saturation. And no, we have identified those key ingredients that will, ignite a faster path to the uptake of an evidence-based practice. But I think Sean almost dovetailed us perfectly when he showed the literature, but also those results that really data is convincing to get more money from the federal government and from the policymakers, the state policymakers, that their money is going to something that's proven and will be effective for the community. And so I also think that I'm optimistic that these results that we're seeing, will help to shorten that gap. That's our goal.
If I could just add something real quick, data, we put so much thought into our metrics and question set back in 2015, 2016, and not to say there's not opportunities to improve, but, as some of the coaches and the folks you interviewed, we struggled lifting up the first portal. And we originally contracted with our friends right down the hall, literally, the Health Industry Data Institute, and then COVID hit. And man, it was, so anyway, a lot of other state spearheads, namely DHSS, they need to leverage some of that Heidi talent. And it took a village for us to get through that. So what I had to do was like, okay, I need an IT vendor. So thank God that ComCare had preempted a relationship with Community Care Link, a local company there in your neck of the woods. And, they've really stepped up to the plate. I wish someone was on here from there, but yeah, they've done really good work. And I know ComCare is pleased with them, but, it just, we need to do better with getting the data in so we can pull it out. But, we finally have a portal that, yeah, it's functional, it's working, and they're doing and building reports out. So just tickled pink about that and super excited when we can start clicking buttons and handing over these data sets quick, because we need this data. And it's kind of embarrassing that to date, I still don't have anything, right? And I know it's not on anybody, but.
That's great. So building on that, Sean, I really want to ask Kristen, a lot of the work that Danielle alluded to is going to be able to really highlight, it seems to me, the outcomes and the avoidance of repeat sort of opioid crises in people who do get access versus those who do not get access to the EPIC program. And it strikes me that one of the real advantages of the work that Ife and Tracy and Danielle and Holly are bringing is to help give you the data and the numbers to be able to demonstrate the impact and the value of unbelievable coaches like Jen on really helping people recover and escape some of the opioid use disorder challenges that they face. From your perspective, I mean, how do you see the import of this data to your work? I mean, I'm sure you've got a palpable feel. It's working really well with a lot of anecdotal stories, but is the data very important? Is some of the effort collaborating with the academic scientists going to pay off once you can better quantify the impact of your efforts?
For sure. Oh yeah. I think there's a lot of different data that's produced. And then of course there's data that we're going over monthly for compliance purposes and what have you. But to me, just the increase in referrals and looking at what we did, the current month compared to what we did the last month. The other thing that we really try to focus on too is the engagement piece. How long is a client engaged in services, and trying to look at linking from a qualitative perspective, like what are some of those factors that keep them engaged longer. So we
how is that working? Are you getting more as you get more experience and work with clients? Are you getting longer engagements over time, do you think?
Jen, what would you say? I think it's taken a little while to.
Honestly, since we do have a self-guided program, it's truly up to the individual, the community member. I think that it just really depends, and especially with the increase in fentanyl, that seems to be harder to keep someone engaged when they're actively using fentanyl. But engagement covers a broad spectrum. It could be just a phone call, or it could be completing treatment. So it's just really hard to gauge that because it is self-guided. We give them we hear what their barriers are, and we help them get connected to services and overcome those barriers, and just let them guide their own recovery.
But I do, just in kind of speaking to what you had said, is just, yeah, data drives a lot of things in how we produce a lot of our different services within Epic. Because if there's a way that we can increase somebody's engagement longer by offering more, or another resource coming into the community or whatever, those are the kind of things that we're looking at when we're looking at the data as it's being collected. So
That's great.
Yeah.
Tobias put a
Jim
question.
Richter.
Oh.
I wondered if I could ask a question.
Yeah, of course.
Yeah, hey, thanks. And sorry I'm driving, so I don't have my camera on, but this was fabulous, fabulous presentation. And I guess where I see you guys taking the field is, Esper really didn't do a good job of documenting engagement and treatment, as you guys have been talking about it. So I had a few questions based on that. I wondered, are there enough treatment slots in the area at the right level of care that people need, or do you guys struggle placing people? And also, what proportion of people who are opioid dependent do you actually get on medication-assisted treatment, given the fact that that seems to predict really good continued engagement?
Sure. Well, in response to your first question, yes, it kind of varies in the timing on if there are, for instance, in housing and different things, if there's availability. I would say since I've come on in the last year, and there has been some increase in recovery houses opening and some increase in services for housing around the metro area, that it's getting better in finding placement. There's still some random times though where we do have a day or two where somebody can get in. Anyway, so that piece can definitely be a challenge. In respect to your second part of your question, can you ask that just one more time? Because I want to make sure I answer it right.
Yeah, sorry, Sean had talked about a study that had found that people who were on medication-assisted treatment tended to engage better in treatment and stick with treatment, and I might be misquoting that. And so it seems to me that one way of increasing engagement is getting everybody who is appropriate for medication assisted treatment on medication. And I was wondering if you had a sense of how you guys are doing on that. What proportion of the people
Right.
are ending up on medication assisted treatment?
I don't have a number of proportion. I mean, I know that's one thing that we're tracking, and we found actually in our data, because we do look at MAT, where we had to change our KPI in that area and go ahead and have another form to use to capture that number better. But what I can tell you is as time goes on and providers are becoming more educated and familiar with MAT, that is opening up more for clients that we have. So historically, I think it's been difficult, just from what I understand, to find providers at times that will go that route for a client needing that. But I think that at least within the last year that I've been here, I know that there's been more education to providers. I know that some of the resources that we have here around the metro, there's been some that have actually opened up some clinics with providers that participate in that. So anyway, I think over time, at least within the last year, I can test to that. We definitely are seeing more of a higher percentage in this area than the year before of MAT, and that's just due to providers offering it.
Well,
That's great. And are there any emergency departments that are initiating, Suboxone in the emergency department in the Kansas City area?
Yep, that would be one of our physician champions, Dr. Doug Burgess, does induction probably every day at University Health.
So I know we're at time, but I know Sean and I are probably eager to say a couple things.
Yeah,
You know-
that's what I was going to try and turn to. So why don't we hear from you, Holly, quickly, and then Sean.
Okay. I will just say, getting back to that, this is a bit frustrating. We want to move that dial of that 17 years. Sometimes when we write grants, I'll say, the MAT piece is the most evidence-based piece of our model. And that's what Sean was showing in that slide or that study that he alluded to, that if we do get people on medication, we can stabilize them and improve all these other outcomes. Yet we have hesitation from the medical community. So it is our hope to address those things in this project to shorten that gap, because that is actually the most evidence for this piece.
So just real quick, from a statewide perspective, when we put together our metric set, one of our hypotheses was if the Sean that participates in pharmacotherapy is going to be engaged in treatment and engaged in recovery much longer than the Sean that isn't. And we're sitting on a very nice sample size from a statewide perspective. Again, our N is over 15,000. So we're sitting on that data, and I'm hopeful that you guys, at least with your N in Kansas City, which is over 1,000 now, that you're going to unearth that too. Again, I don't know. Is that the story in KC? I sure hope so. Another thing that I'll share just real quick, I met with Community Care Link a couple weeks ago to build out more forms, and something else that the coaches spend a lot of time doing, I'm thankful for, is social determinants of health, to basically add a form to bean count and aggregate how many housing resources, how many transportation needs were filled, childcare, so we can stack that in addition to the other treatment arrays and other resources that these coaches are providing. Again, they treat the whole the person, and that's one of the beautiful things about this model is they care for me completely, not just in part. So I'm done.
Well, I just can't thank all of our speakers enough. I mean, that was a fabulous update, and learning how the program's evolved and seeing its impact. And we really look forward to more insights, I guess, in another year of exactly when you can bring all the qualitative and quantitative work together, and we can hear how the program has evolved, and hopefully you'll have more stable funding, more stable coaches. But it's very inspiring, very tough problem, and we really are so appreciative of you tackling this problem but sharing your experiences with us. So thank you so very much.